Electrolyte derangements are among the most frequently encountered abnormalities on any inpatient panel, and how you manage them matters as much as whether you catch them. Overcorrect a chronic hyponatremia and you risk osmotic demyelination. Undertreat a hyperkalemia and you risk cardiac arrest. This isn't a review of definitions. It's a review of where the guidelines, the pitfalls, and the pearls actually live. For derangements deserve reflexive urgency. Hyperkalemia, which can arrest the heart within minutes. Symptomatic hyponatremia, which can herniate the brain. Hypercalcemic crisis, which can precipitate coma and renal failure. And severe hypophosphatemia, which can drop a ventilated patient's diaphragmatic function out from under them. As a quick reference before we dig into the nuance, sodium 135 to 145, potassium 3.5 to 5.0, chloride 96 to 106, bicarbonate 22 to 28, calcium 8.5 to 10.5, magnesium 1.7 to 2.2, phosphate 2.5 to 4.5. Every lab has its own reference intervals, so treat these as orientation, not gospel. Run every abnormal value through the same 4-step filter before you act. Confirm it isn't an artifact, hemolysis, delayed processing, or a line draw. Establish acuity, since the same number carries different risk if it developed over hours versus weeks. Assess volume status and context. Only then target the underlying driver, rather than chasing the number in isolation. A few thresholds should trigger reflexive escalation regardless of the clinical picture. Potassium above 6.5, or any ECG change. Sodium below 120, or a rapid acute drop. Corrected calcium above 14, and phosphate below 1.0 milligrams per deciliter in a ventilated or malnourished patient. Treat the patient, not the lab value. An asymptomatic chronic sodium of 128 in a stable outpatient does not need the same urgency as an acute, symptomatic drop to the same number in a post-operative patient on hypotonic fluids. Match your pace of correction to the pace at which the derangement developed. Let's start where the most correction errors happen: sodium. Before we get into specifics, every electrolyte decision you make should answer 3 questions. Is this real? How fast did it happen? And what's driving it? Keep that framework running in the background for everything that follows. Serum osmolality is the first branch point in any hyponatremia workup, not the sodium number itself. Measured osmolality below 275 confirms true hypotonic hyponatremia, and that's where volume status assessment takes over. Osmolality in the normal 275 to 295 range points to pseudo-hyponatremia from severe hypertriglyceridemia or paraproteinemia, a lab artifact from displaced plasma water. Osmolality above 295 means translocational hyponatremia, most commonly hyperglycemia pulling water out of cells and diluting the measured sodium. Once you've confirmed true hypotonic hyponatremia, volume status does the rest of the sorting. Hypovolemic points to renal or extrarenal sodium loss. Check urine sodium to separate diuretics and salt-wasting nephropathy from GI losses and third spacing. Euvolemic is the SIADH-dominated category. Hypervolemic means heart failure, cirrhosis, or nephrotic syndrome, all sharing impaired free water excretion despite volume overload. Don't forget to correct for glucose before you commit to a hyponatremia workup. The classic CATS factor drops sodium by 1.6 milliequivalents per liter for every 100 milligrams per deciliter of glucose above normal. Hillier's 1999 data suggests 2.4 is more accurate, particularly once glucose climbs above 400. The euvolemic bucket is where most diagnostic dilemmas live. SIADH remains the leading cause, but don't anchor before ruling out hypothyroidism and, critically, adrenal insufficiency. A random cortisol won't cut it if suspicion is high. Primary polydipsia and beer potomania round out the differential, both distinguished by a low urine osmolality that SIADH won't give you. A 68-year-old on sertraline for 6 weeks presents with confusion. Sodium is 119, serum osmolality 245, urine osmolality 380, urine sodium 45, and she's clinically euvolemic on exam. This is textbook SSRI-induced SIADH. Stop the offending agent, restrict free water, and consider salt tablets or a loop diuretic if restriction alone isn't moving the number. Don't confuse SIADH with cerebral salt wasting in your subarachnoid hemorrhage patients. The treatments are opposite. SIADH is euvolemic or mildly volume expanded and gets fluid restriction. Cerebral salt wasting is volume depleted from renal sodium loss and needs salt and volume replacement, not restriction. The Barter-Schwartz criteria still anchor the SIADH diagnosis. Hypotonic hyponatremia, inappropriately concentrated urine above 100 milliosmoles per kilogram. Urine sodium typically above 30 with normal salt intake. Clinical euvolemia and normal thyroid, adrenal, and renal function. Osmolality sorts the mechanism. Volume status sorts the etiology, and glucose correction keeps you from chasing a mirage. Get the workup right before you touch the treatment plan. Osmotic demyelination risk isn't uniform. It clusters in specific patients. Sodium under 105, hypokalemia, malnutrition, alcohol use disorder, and underlying liver disease all independently raise the risk, and these patients need the more conservative correction limits. The European guideline and the American expert panel converge on similar limits through slightly different reasoning. Both cap correction around 10 to 12 milliequivalents in the first 24 hours. The American panel adds an 18 milliequivalent 48-hour ceiling and drops to 8 milliequivalents in 24 hours for high-risk patients. In practice, write the correction limit as an order before you start treatment, not after. Average risk patients, 10 to 12 in 24 hours, 18 in 48 hours. High-risk patients, hold the line at 8 in 24 hours. Both groups get a practical daily target of 4 to 8 milliequivalents to leave margin for error. For severe, symptomatic hyponatremia, seizure, obtundation, coma, bolus 100 to 150 milliliters of 3% saline over 10 to 20 minutes. And repeat up to 2 or 3 times if symptoms persist and sodium hasn't risen by 4 to 6 milliequivalents. Reassess sodium after each bolus, not on a fixed schedule. Overcorrection happens fastest in hypovolemic hyponatremia. Once volume repletion shuts off ADH and the kidneys start free water diuresing on their own, sodium can climb far faster than you intended. Watch hourly urine output closely in these patients. A sudden diuresis is your warning sign. If you overshoot the correction limit, the DDAVP-clamp and D5W re-lowering strategy is your rescue. Desmopressin prevents further free water excretion, while D5W dilutes the serum sodium back down toward the target trajectory, a controlled re-lowering rather than letting the kidneys run away with the correction. One more nuance before we move to hypernatremia. Acute hospital-acquired hyponatremia, developing in under 48 hours, tolerates faster correction than chronic hyponatremia. The brain hasn't had time to adapt osmotically. If this level of detail is useful, subscribing helps this kind of clinical content keep reaching you. Set your correction ceiling before you start treating, know your patient's ODS risk factors, and have the DAVP-D5W rescue plan ready before you need it, not after. Hypernatremia almost always means free water deficit, not sodium excess. The differential is about where the water went. The free water deficit formula gets you a starting estimate, not a final prescription. Total body water runs roughly 60% of weight in men, 50% in women, and less in the elderly. Replace half the deficit over the first 24 hours, then reassess. Split the causes by where the water is going. Renal water loss points to central or nephrogenic diabetes insipidus. Extrarenal loss is insensible losses, burns, or GI free water loss. Osmotic diuresis from uncontrolled hyperglycemia or mannitol drags water out with it. And don't overlook iatrogenic sodium gain. Hypertonic saline or excess sodium bicarbonate boluses. When diabetes insipidus is on the differential, the desmopressin challenge separates central from nephrogenic. Give desmopressin and recheck urine osmolality. A rise of more than 50% means central DI responding to replaced ADH. Minimal change means the kidney isn't responding, and you're dealing with nephrogenic DI instead. Correction limits mirror the hyponatremia side of the ledger. Don't drop sodium faster than about 10 to 12 milliequivalents per 24 hours, or you risk cerebral edema from the brain's accumulated osmolytes pulling water back and too fast. Both directions carry risk here. Correct too fast and you risk cerebral edema, seizure, and herniation from osmotic water shift into brain cells. Correct too slowly in a genuinely symptomatic patient, and you prolong altered mental status and seizure risk from the hypertonicity itself. Free water deficit gives you a starting point, The desmopressin challenge sorts central from nephrogenic DI, and the same conservative correction ceiling applies as it did for hyponatremia, just in reverse. Peak T waves are the earliest ECG sign, typically appearing above 5.5 to 6.5 milliequivalents per liter. But don't anchor on the ECG alone. Findings are notoriously variable, and the absence of ECG changes does not exclude dangerous hyperkalemia. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. Stratify urgency by level and by ECG, not by level alone. Mild, under 6.0 without ECG changes, can often be managed with oral binders and outpatient recheck. Moderate, 6.0 to 6.4, needs active treatment. Severe, 6.5 or higher, or any ECG change at any level, is an emergency. The sequence matters. Calcium first to stabilize the myocardial membrane. It buys you time, but doesn't lower potassium at all. Insulin with dextrose next to shift potassium intracellularly, with albuterol as an additive shift agent. Only after stabilization and shifting do you move to actual potassium removal. Exact numbers. Calcium gluconate 10%, 10 to 30 milliliters, 4/2 to 5 minutes. Repeatable if ECG changes persist at 5 to 10 minutes. Insulin 10 units regular with 25 grams dextrose. That's 50 milliliters of D50, over 15 to 30 minutes. Watch glucose closely afterward. Hypoglycemia is the most common complication of this step. Most hyperkalemia in outpatients traces back to a drug combination, not a new diagnosis. RAS inhibitors plus potassium-sparing diuretics plus NSAIDs is the classic triple threat. Each independently impairs potassium excretion, and together they compound. Before you treat, rule out pseudo-hyperkalemia, a spuriously high value that doesn't reflect the patient's true potassium. Hemolysis from a difficult draw, prolonged fist clenching with the tourniquet on, and marked thrombocytosis or leukocytosis can all falsely elevate the result. The insulin-dextrose combination has one dominant risk worth building a protocol around: delayed hypoglycemia, which can occur several hours after administration, especially in renal impairment where insulin clearance is prolonged. One more pearl before moving on. Chronic dialysis patients are often adapted to a higher baseline potassium, and for calcium in that population carries a real risk of calcium phosphate precipitation. Use it cautiously and only with clear ECG changes. If this kind of nuance is useful, a like helps more people find it. Calcium stabilizes, insulin and albuterol shift, and only then do you remove, and always rule out pseudo-hyperkalemia before you commit a stable-looking patient to an aggressive protocol. Refractory hypokalemia that won't correct despite aggressive repletion has one usual suspect: unmeasured or under-replete magnesium. ECG changes in hypokalemia are subtler than in hyperkalemia: flattened T waves, ST depression, and the classic U wave, best seen in the precordial leads as potassium drops below 3.0. Skip the transtubular potassium gradient. It's built on assumptions about medullary urea handling that have since been shown invalid, and it's no longer uniformly recommended. Use the urine potassium to creatinine ratio instead. Above 13 milliequivalents per gram suggests renal potassium wasting. Below that, look extrarenal, GI losses, transcellular shift, or poor intake. The mechanism behind the magnesium-potassium link. Intracellular magnesium normally inhibits the ROMK channel, limiting potassium secretion. Deplete magnesium, and that inhibition is lost, so the kidney keeps wasting potassium no matter how much you replace. Repleting magnesium first is what breaks the cycle. Untreated, hypokalemia's downstream complications compound each other. Ventricular arrhythmia risk climbs, especially with concurrent digoxin. Rhabdomyolysis can develop with profound depletion, and an ileus can mimic a surgical abdomen if nobody's checked a potassium level. Replacement rate has hard ceilings for patient safety: 10 milliequivalents per hour through a peripheral line, up to 20 per hour through a central line with continuous cardiac monitoring, and central line infusions above 10 per hour should never run through a line terminating near the right atrium to avoid local cardiotoxic concentration. Check magnesium reflexively in refractory hypokalemia. Retire the TTKG in favor of the urine potassium creatinine ratio. and respect the infusion rate ceilings. Every trainee learns the pain correction formula. Corrected calcium equals measured calcium plus 0.8 times the difference between 4.0 and the patient's albumin. Fewer learn that recent large cohort data call its accuracy into question. Myth: the albumin-corrected calcium reliably reflects true calcium status. Fact: a large JAMA network cohort of over 22,000 patients found unadjusted total calcium actually correlated better with ionized calcium than the pain-corrected value did, and the gap was widest in the hypoalbuminemic patients the formula was designed for. In critical illness, CKD, or when the result changes management, get ionized calcium directly. Chvostek's and Trousseau's signs still earn their place at the bedside for symptomatic hypocalcemia. Chvostek's: tap the facial nerve anterior to the ear. Watch for ipsilateral facial twitching. Trousseau's is more specific. Inflate a blood pressure cuff above systolic for 3 minutes and watch for carpal spasm. It's positive in a higher proportion of true hypocalcemia than Chvostek's, which has more false positives in normocalcemic patients. Hyperkalemia splits cleanly by PTH. PTH-mediated means primary or tertiary hyperparathyroidism. PTH-independent means malignancy, either PTHRP-driven humoral hypercalcemia or local osteolytic metastases, plus granulomatous disease and vitamin D excess. A suppressed PTH in a hypercalcemic patient should send you straight to a malignancy workup. Hypercalcemic crisis management is sequenced by onset of action. Isotonic saline first for volume expansion and renal calcium clearance. Calcitonin next for its fast onset, but expect tachyphylaxis within 48 hours. Bisphosphonates like zoledronic acid provide the durable effect, but take 2 to 4 days to peak. Denosumab is your fallback in renal impairment or bisphosphonate refractory disease, since it isn't renally cleared. NICE criteria stratify refeeding risk before you write the first tube feed order. High risk meets any one of BMI under 16, unintentional weight loss over 15% in 3 to 6 months, minimal intake over 10 days, or pre-existing low potassium, phosphate, or magnesium, or any two of a milder version of those same criteria. The refeeding cascade starts the moment carbohydrate hits the gut. Insulin surges in response to the glucose load, and that insulin drives phosphate, potassium, and magnesium into cells en masse, right as thiamine stores, already depleted by starvation, run out. The clinical result: sudden multi-electrolyte collapse, plus a risk of VRNI keys if thiamine isn't replaced first. Phosphate is the hallmark and typically the earliest to fall, often within 72 hours of restarting nutrition, with severe hypophosphatemia defined below roughly 0.6 millimoles per liter. Potassium and magnesium tend to trail slightly behind on the same downward curve. Trust ionized calcium over the corrected formula when it matters. Keep Chvostek's and Trousseau's in your physical exam. Sort hypercalcemia by PTH, and screen every malnourished patient against NICE criteria before you feed them. Before you sign off on any electrolyte panel, run this checklist. Calculate the anion gap. Calculate the osmolar gap. If the anion gap is elevated, apply your corrections for glucose and albumin. Look at the trend rather than the isolated value, and review the medication list for contributing agents. The anion gap is sodium minus the sum of chloride and bicarbonate, normally around 8 to 12 milliequivalents per liter. An elevated gap narrows your differential to a specific set of unmeasured anions. A normal gap with acidosis points you toward GI bicarbonate loss or renal tubular acidosis instead. Fluid choice is itself an electrolyte decision. The SMART trial, Semler and colleagues, New England Journal 2018, randomized over 15,000 critically ill adults and found balanced crystalloids reduced 30-day major adverse kidney events to 14.3% versus 15.4% with saline, a number needed to treat of 94, with the benefit concentrated in sepsis and larger fluid volumes. Myth: normal saline is always the safe default crystalloid. Fact: high-volume saline resuscitation drives a hyperchloremic metabolic acidosis and, per SMART, carries a measurably higher risk of adverse kidney events than balanced solutions in critically ill patients, particularly those with sepsis. Balanced solutions aren't free of trade-offs, though. Lactated ringers carries calcium, which classically complicates co-administration with citrate blood products and certain medications. Cost and formulary availability still favor saline in many settings, and the absolute benefit, while statistically real, is modest at the individual patient level. Carry this list into every panel review. Is it real? How fast did it happen? What's driving it? Does the correction have a hard ceiling? And does the fluid choice itself need reconsidering? Quick case to close. A cirrhotic patient's sodium rises from 118 to 128 within 6 hours after an albumin infusion suppresses ADH. What's the next best step? Serum electrolytes reward the clinician who treats the trajectory, not the snapshot. Set your ceilings, know your rescue strategies, and let the guidelines do the heavy lifting on the numbers you don't need to memorize. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.